Hi, my name is Mihir Thacker and I'm a pediatric orthopedic surgeon at the Nemours Children's Hospital in Wilmington, Delaware in the United States. Today we are going to talk about pinning of slipped capital femoral epiphysis. Every slip needs to be stabilized. Whether or not in-situ screw fixation is the appropriate treatment choice for all severities of slips is somewhat controversial, but it nevertheless remains a common treatment option. This can be done either on a fracture table or on a radiolucent flat top table. I prefer the fracture table. You also need a good radiology technician who will give you good fluoro images, and the room needs to be set up so you can see the fluoro screen through the shower curtain or around the shower curtain if you're using one. The unaffected side can be held in a well leg holder with flexion, abduction, external rotation to give you enough room to get the fluoro in from the contralateral side. However, if this is the position for the well leg, it does put the well leg at risk for compartment syndrome. So this needs to be checked frequently throughout the case. If a flat top radiolucent table is being utilized, a bump under the affected side is quite helpful in order to get a good lateral view. I prefer the scissors position, so the patient is placed on a fracture table with the affected leg slightly flexed and the non-affected side slightly extended. And this allows for the C-arm to come in easily from the non-affected side. It also holds the non-affected leg in stable position, minimizing the risk of compartment syndrome. Legs can be switched in the fracture table if bilateral screw fixation is planned. The first step is to ensure that we get a good AP view, and if there is obligate external rotation or a fixed external rotation deformity where the leg cannot be internally rotated, then the C-arm may need to be rotated over to get a proper AP. The lateral view is even more critical, and depending on the severity of the slip, one may need to keep the C-arm at an angle less than a full 90 degrees in order to get the best possible view of the femoral head and neck. Once these are obtained, the radiology tech is asked to mark out the position of the machine as well as the height and depth at which these images are best obtained. This helps minimize any confusion intraoperatively. After prepping and draping in the usual fashion, covering the proximal thigh with a shower curtain, we mark the entry point for the nail using the intersection technique. A guide wire is laid on the proximal femur on both the AP and the lateral views such that the wire ends up in the middle of the epiphysis perpendicular to the physis, and the wire trajectories are marked on the AP and the lateral views, and the intersection is where the incision is made. I prefer to make my incision along the trajectory of the AP guide wire, and this therefore is an oblique incision, and I prefer this because the usual struggle is trying to get the right amount of version, which is easy if the incision is along the trajectory of the AP wire. Once the incision is made, then I will bluntly dissect down to the bone with a blunt clamp. Now, once the bone is reached, one needs to plan how to place the guide wire for the screw. So the entry point of the guide wire starts distal to the intertrochanteric line, but above the level of the lesser trochanter. And the worse the slip, the further anterior one needs to bring the guide wire. The guide wire trajectory is such that it is perpendicular to the growth plate on both the AP and the lateral views and is aimed towards the center of the epiphysis on both views as well. This is confirmed on both the AP and the lateral fluoroscopy views. And then the guide wire is advanced into the epiphysis, ensuring that it is central on both the AP and the lateral. A depth gauge is then utilized to measure the length of the screw. We then use a cannulated drill bit to drill over the guide wire, ensuring that there is no binding of the wire. Intermittent fluoroscopy shots are utilized to confirm that the wire is not being advanced into the joint. I usually stop at the level of the growth plate. If the bone is very sclerotic, then you can certainly drill across the growth plate as well. Once the drilling is complete, the appropriately sized screw is then mounted over the wire and advanced into the epiphysis such that there are in between 3 and 5 threads of the screw in the epiphysis, and the tip of the screw is approximately 5 millimeters shy of the articular surface. This helps minimize risk of intra-articular penetration. The ideal SCFE screw is a fully threaded 6.5 or 7.3 millimeter cannulated cancellous screw with its entry just distal to the intertrochanteric line but proximal to the lesser trochanter, perpendicular to the growth plate on both the AP and the lateral as far as possible, and with the tip of the screw being in the central 25% of the epiphysis on both views, with the tip being shy of the articular surface by approximately 5 millimeters. There should be 3 to 5 threads of the screw in the epiphysis. This is true for a Synthi screw design. And once the screw is placed, then the tip should be checked using live fluoroscopy in the around the world fashion, with approach of the screw towards the articular surface and then rotating it beyond to confirm that there is lack of intra-articular penetration by the screw. Errors in in situ screw fixation of slipped capital femoral epiphysis. For those who are unfamiliar with the slip anatomy and are used to pinning of proximal femur fractures, we tend to place the screw along the axis of the neck and not towards the center of the epiphysis, and this may result in inadequate fixation of the slip with lack of appropriate purchase in the epiphysis, or worse still, intra-articular penetration of the screw. If the screw starts too far proximal, that is, proximal to the intertrochanteric line, then the screw head can cause impingement by itself, and this may result in persistent pain. And because the screw is in soft metaphyseal bone with persistent flexion beyond what is permitted by the acetabulum, there may be some degree of loosening of the screw and possibly slip progression. The other factors that may potentially cause increased risk of slip progression are if the screw is too long or if the bone quality is poor and there's not enough purchase in the epiphysis with too few threads. If the guide wire starts distal to the lesser trochanter, and certainly if the screw starts distal to the lesser trochanter, because this is a high stress location, there is a risk of subtrochanteric fracture. So care should be taken to get the guide wire to start above the level of the lesser trochanter. So it is not just a screw. This is a screw that requires some degree of orientation to the pathoanatomy of the proximal femur, and you need to get it right the first time in order to minimize risk of major complications. Please let me know if you have any questions, and this is a QR code to the link that will take you to the YouTube channel where this video and other videos are housed. Thank you.